All right, so welcome everybody to the Queen's West Oahu Virtual Speaking of Health Lecture Series. My name is Eric Barsatan, and I'm the Manager of Physician Relations and Medical Staff Services here at the Queen's Medical Center, West Oahu. The title of today's Speaking of Health is Focus Ultrasound, a new treatment for tremor. Right now, throughout the presentation, we could ask all our viewers to be on mute. And if you have any questions, please type your question in the chat box, and your answer will be answered during the Q&A portion by our presenters. And at this time, I'm honored and privileged to introduce our speakers, Dr. Fay Gao, a neurologist, and she's a neurology program director of neuromodulation, as well as Dr. Michon Morita, who is a neurological surgeon, and both works here at Queen's. Proceed, doctors, you may now proceed with your presentation.
Thank you, Eric. So I'm just sharing my screen. Can everybody see the slide?
Yes, we can.
Okay, great. So thank you for inviting us, and I'm going to start out with the first portion of this talk, and Dr. Morita will give the second portion. So these are just details about us. We don't have any financial disclosures. Okay, so here's our agenda. So I'm going to start by discussing essential tremor. Essential tremor is a very common condition. It's characterized by a tremor or a regular back and forth movement of typically the bilateral or both upper limbs, the arms, on action. Now, tremor can occur in other body parts as well, including the head and the neck, as well as the voice. In many people, they've noticed that tremor is responsive or reduces with small amounts of alcohol. And in about half the cases, this is familial, meaning there is a history of this same or similar tremor in multiple members of the family. And this is the most common movement disorder, which affects about 2% of the population, which means about 7 up to 10 million people in the US. Majority of which, however, are undiagnosed, as many people don't seek care. The cause is ultimately unknown, but usually testing with things like MRI and nerve conduction studies is all normal. So this is not thought of to be caused by structural problems of the brain or the nervous system. While in most cases it's benign, there are individuals for whom tremor causes significant difficulty doing day-to-day tasks such as writing, eating, drinking, and dressing, as well as other tasks. I'm going to show you a video of a patient of mine with a classic essential tremor. And in this video, we're going to see some tasks with his hands. So this tremor is most prominent on action, meaning holding the hands up and performing other movements with the hands. And you can see it's present in both hands, but worse on the right hand than the left. And essential tremor can be asymmetric, meaning one side is worse than the other. So you already get a sense of his tremor from this video. In the next video, I'm going to show him holding an empty cup and pretending to drink from it. And you can see he sort of automatically grabs it with both hands, as many people with tremor have found that using both hands helps a little bit to reduce the tremor. And you can see kind of how large and severe the tremor is, especially on his right hand, his dominant hand. And if you can just imagine what would happen if he had a full cup. Okay, and then here's another summary video, kind of compiling other patients with tremor and how it affects how they perform day-to-day activities. So as you guys can see, tremor can lead to a very high burden of functional impairment, as well as social stigma, often leading to embarrassment, avoidance of social events, and depression and anxiety. And despite the high frequency and occasional severity of symptoms, again, many people don't seek care or they're told that there are no effective treatments, which is not true. So there are many treatments for tremor, typically starting with medications. There's multiple categories of medications that can work to reduce tremor. Although in about half the time, they are either ineffective or produce undesirable side effects. So while they're often a good choice to begin with in treating somebody who has bothersome tremor, sometimes they're not sufficient. There are also wearable devices, such as a watch device that provides stimulation to the nerves, weighted gloves, as well as other assistive devices and instruments. These can give a slight improvement in tremor, but generally not super effective. And finally, there are procedural interventions, i.e. surgeries and other procedures. And we'll talk a little bit more about that. Okay, now I'm going to move on to Parkinson's disease. So Parkinson's disease, it's a different condition. This is a progressive neurological disorder that does involve breakdown of neurons in the brain that control movement. And what this often results in is tremor of the hand. Usually this is only on one side and typically in the resting position, but can involve tremor in action as well. And people with Parkinson's often have other problems of movement, including slowness, stiffness, walking, and balance difficulties. And in addition to movement problems, they also can experience non-movement symptoms like cognitive impairment, sleep problems, mood impairment, constipation, and other symptoms. So I'm going to show you some videos of patients with Parkinson's disease. And a sort of a little bit of a simplification is that in contrast to essential tremor, Parkinson's disease oftentimes only happens on one hand, and it's more prominent on rest, which you can see with this lady. So you see her right hand is shaking when she's not using it. But in other patients, the tremor can happen both on rest and actions as well. So you can see. So she has tremor in sort of all different positions. Okay. And in this video, you'll see that this woman with Parkinson's disease, again, has a very classic type of resting tremor on one side only. And she also has, I'll replay that again. She also has slowness of walking. You can see her arms don't swing very well. So she's got a lot of the other symptoms of Parkinson's disease as well. Like essential tremor, there are treatments for Parkinson's disease, which are typically aimed at all of the symptoms. For the motor symptoms of Parkinson's, there's a number of options, but typically levodopa is the best and strongest. However, some patients some patients have adverse side effects, or their tremor doesn't respond to levodopa, which can happen in up to 8% of people with Parkinson's. So for patients with this refractory tremor, where medications either are ineffective or cause undesirable side effects, a referral for surgical consultation is recommended. And I'm going to stop here and have Dr. Morita take over and discuss them.
Great. So first we'll talk about lesional therapy. So lesion involves creating a therapeutic area of damage in the motor thalamus with the goal of reducing the tremor on the opposite side of the body. And when I was in my training in the 90s, we'd still see a fair number of patients who had radiofrequency lesions. So this is where an electrode is passed into the motor thalamus. Test stimulation would be done, and then electric current would be run through to intentionally burn an area of tissue there. So this was, it's an invasive procedure, but it was good even for patients who might not have the home support or might not be medically able to undergo deep brain stimulation. So we're going to talk more about focused ultrasound, which is a less invasive way of creating a therapeutic lesion. Another way to create a therapeutic lesion would be with gamma knife. So focusing radiation as a single fraction treatment to create a therapeutic lesion there. So deep brain stimulation, you can see the image from Medtronic below, is implantation of a brain electrode in one motor thalamus or sometimes both motor thalami. It's done in a two-stage procedure separated by about a week. And the electrodes are connected to a pulse generator. And the movement disorder neurologist can program the device to optimize the therapeutic reduction of tremor and minimize any side effects. It's probably the procedure that is most, gives probably the best results, but it is more invasive. It requires a level of participation and health from the patient and family support that not everyone is a candidate for. And so not everybody can have that procedure. So Dr. Gao has put together this great slide that talks a lot about the history of the various procedures. So especially the radiofrequency lesions were very common in the 1950s all the way up until the maybe 1990s. There are a few of them still done now, but not so many as before. Deep brain stimulation for essential tremor was approved in 1997, and for Parkinson's disease, deep brain stimulation is the most frequent surgical intervention procedure done. So focused ultrasound has been approved since as a treatment for essential tremor since 2016, and as a treatment for Parkinson's disease since 2018. And since 2023, we can do the second side of a patient who has bilateral tremor. So typically we'll treat the side that's worst or the dominant side first, but we can actually treat the second side now since 2023. Okay, so what is focused ultrasound? So focused ultrasound is a really high-tech, amazing, it's like a miracle of modern science, a way of administering non-invasively ultrasound beams that pass through a water bath, through the patient's skin, through the skull, through the brain, and they all converge on one point to raise the temperature and create a thermal lesion in the brain tissue. The procedure is done in the MRI scanner, because the MRI scanner can localize some important anatomic landmarks that are used to find the motor thalamus, but also because MRI scanning can do continuous thermography, so we can measure the actual temperature in the brain at the target and in the surrounding areas, so we can be sure that the therapeutic lesion is going to be the right size, the right shape, the right anatomic location, and that adjacent structures like the internal capsule and the somatosensory tracts won't have any damage to them. The main objective of treatment is reduction of tremor with as few side effects, minimal complications. So this is a little image. It's a graphic of how the device works. So it is installed in our MRI scanner. We have a special brand new MRI scanner with the device built into it. It is a transducer that has 1,026 ultrasound sources. And it was trying to show how we localize the target. We usually localize the target by the relationship to the anterior commissure and the posterior commissure, also by the thickness of the third ventricle. And also we do tractography, so MR diffuse tensor imaging to find the adjacent brain tracts for every case. The procedure is done with the patient awake, and we're testing the patient during the procedure. And again, as the slide points out, there's no radiation exposure, so it doesn't increase a person's cancer risk. So how many patients have been treated? So the information from Insightec says so more than 10,000 patients have undergone the treatment already, and that as of 2021, focused ultrasound is performed more than DBS for treatment of essential tremor. So who is a candidate for focused ultrasound? Okay, so patient has to have essential tremor or tremor predominant Parkinson's disease. For essential tremor, they have to be 22 years old. For Parkinson's disease, they have to be at least 30 years old. They can't have contraindications that would prevent them from having MRI scanning. So they cannot be severely claustrophobic and unable to tolerate MRI scan. They cannot have shrapnel or something that would be a contraindication. And if they have a pacemaker, the pacemaker has to be MRI compatible. They have to be able to follow instructions, and they have to be able to speak and communicate because they get tested usually about 5 or 6 times during the procedure. And then they have to be able to tolerate the discomfort of the actual thermal lesion. Before the procedure, they undergo a special head CT scan to measure the skull density ratio, which is a measure of the inhomogeneity of the bone of the skull. And the reason for that is that maybe about 20% of patients will have a skull anatomy that does not allow enough of the ultrasound waves to pass through the skull and get into the target. So there are some patients that we think are a good candidate otherwise, but we have to turn them down if the skull anatomy is unfavorable. Other contraindications would be pregnancy or inability to lie still enough, certain brain tumors and strokes, bleeding disorders, alcohol abuse, things like that. So this is the, I think this was the first study that showed the efficacy of ultrasound thalamotomy. It actually was done with real sham procedures, showing that the patients had a sustained reduction of tremor and that it was very far better than the control group. So here showed 47% of patients in the treated group had this big reduction compared to 7% in the sham group. Patients also had improvements in their day-to-day function and in their reduction of their functional disability. This was a follow-up article published in 2022 and updated in 2023 showing 4-year and 5-year follow-up. And basically the results shows that the improvement in tremor was sustained and that there were no delayed side effects. So any side effects that could occur, they become apparent immediately. And if they don't have any side effects from the procedure, they're not going to develop them later. So what are the steps involved? On the date of treatment, the patient comes in, they have their head shaved, so the whole head has to be shaved, everything except the eyebrows, because the hair contains little air bubbles that would interfere with the conduction of the ultrasound waves. The patient has a stereotactic frame applied, so they have to have local anesthetic injected in the scalp, and the frame is held on. It keeps the head immobile to within 1 millimeter. During the procedure, the patient is positioned in the MRI scanner with a water bath that's allowing the ultrasound waves to go through, but it still allows MRI scans to be obtained. And then we do usually 3 test sonications. So these are low-level ultrasound that just causes a slight elevation in temperature. And that these are done for calibration to confirm that the target, that the lesion, sorry, that the temporary thermal lesion is the size, shape, position that we want. And then we do an additional one at a slightly higher temperature, still temporary, looking to see if there are any side effects and just looking to see if there's a reduction of tremor. And if we're happy with that, then we do 2 therapeutic lesions where we're actually trying to create kind of a football-shaped area of damage in the motor thalamus. So
during the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects.
sorry about that. That's from Inside Tech. That's we don't have that serene music playing during the actual procedure. So our unit, Queens installed this unit, and we did our first treatment on February 1st. So this is one of our first treatments. You can see Dr. Michiko Bruno. You can see Corey and Todd, our MRI techs, and then my Inside Tech trainer, David Tilden from the mainland. So like the video shows, we temporarily heat up that area. We retest the patient again, and then if we're based on the temperature rise, we would recalculate a larger temperature rise. Typically want it to be about 56 degrees is enough to create a therapeutic lesion. If we're unsure whether or not a therapeutic lesion has occurred, we can actually do an MRI scan with the patient still in there, and we can do a quick diagnostic one. So all of our patients have had immediate sustained relief of their tremor. So today we just treated our 11th patient. So the whole procedure lasts about 2 to 3 hours. Today we put a frame on at 7:30 and removed the frame at 10 o'clock. It's done awake. We try no sedation is preferred so the patient can really answer our questions, and so we can maximize the amount of tremor so we can see an actual reduction. Afterwards, we monitor the patient briefly to just make sure they're not nauseated and that they're not unsteady, and then we discharge the patient home. And all of our patients were able to be discharged home. So published side effects include headache, numbness and tingling, gait imbalance, and most of these would resolve by about 2 weeks after the procedure. I think we've been very careful with our patient selection. So far, we don't have any patients have any numbness or tingling. We definitely have seen patients have gait imbalance, but none of them have lasted beyond 2 weeks. And none of the patients have described headache that lasted beyond a few days after the procedure. So the published 5-year follow-up is about 20% of patients can have numbness and tingling. It's commonly in the tip of the tongue or maybe in the fingers. But in most patients that have numbness and tingling as a complication of the procedure, it doesn't interfere with their function. So this is our actual team on the day of I think on the day of the blessing. So this is our nurse Fleur, our Vice President Jen, me, Dr. Gao, Dr. Bruno, and our Corey and Todd, our MRI techs. So this is a patient. I want to show an actual patient on the date of his treatment. This was our very first patient. He is about, sorry, how do I go back? He's about 70 years old. He's from Kauai, and he works as an accountant. And he did a lot of big corporate accounts, but he said he had to retire because he just could not type because his left-hand tremor was so severe. In addition, he retired to a small farm in Kauai. He said he has a hard time doing farm chores. And I later learned that he liked to play ukulele and guitar, and he had to give up all those things because his left-hand tremor was so severe. This is really typical of the kind of patients we see. These are patients where the tremor is not just an embarrassment to them, it actually interferes with their functions, sometimes interferes with their ability to work, their ability to get things done. And when they have exhausted all of their workarounds, then they're willing to consider an interventional procedure like this. So, but his is, his is pretty severe tremor, but we have plenty of patients just as severe. So this is actual day of treatment. You can see Dr. Gao and me were testing the patient. We test usually their strength in the involved side. We test their ability to draw the spirals in the upside down position. We test, have them pretend to be drinking out of a water bottle while the procedure is being done at each stage. This is the treatment console, and you can see there the hot spot is where the brain got heated up. In this case, this was a therapeutic lesion. It was heated up to 55 degrees Celsius. So that's going to be enough to cause a permanent lesion that will give sustained relief. But you can also measure the temperature in the areas around there by moving the cursor around. So this is the same patient right after the procedure is done. And he had tears in his eyes. He was so pleased with the reduction of tremor. He was feeding himself with his left hand. He was holding a cup. We had some operational issues with the paper getting all wrinkled up, but otherwise, you can really see he's had a big reduction of tremor. He told me when he saw this video, he said, I was doing it really slowly because I'm used to not being able to make a spiral faster, but he said, I could do that much faster now. And then he came back and visited us, and he brought his ukulele, and he wanted to show like how much better he was. And he played classical music on the ukulele, and he said he hasn't played for 10 years because of the severe tremor. So he did have a little bit of dizziness after the procedure. He had no numbness, and by 2 weeks after the procedure, the dizziness had resolved. So this is another case. I just wanted to show the spirals for this patient. Because it's a story that touches me personally. This patient was a doctor whom I've known for more than 20 years. He actually helped to, he gave the epidural anesthetic for my wife when my oldest child, my son, who's now 19 years old, was born. And at that time, he had no visible tremor. He put that epidural in it felt like just 15 seconds. But he said his tremor kept getting worse, and he eventually had to retire from his work as an anesthesiologist because the tremor just got so severe. He's right-handed, and this is the right-handed testing. So he's supposed to write down, this is a sample of my best handwriting. And he started writing, and he just gave up because he couldn't write legibly at all. So this is a before and after. And then his handwriting is much better. His tremor is really functionally much better. So this is really a collaborative effort. I mean, I have to thank Dr. Bruno and Dr. Gao for bringing this technology here and for helping to convince Queens to put it here, and for going through all the operational hurdles to actually get it up and running. Dr. Ferdinand Hui helps us with our imaging analysis on these pre and post treatments. And it's been really a great collaboration for me to work with other doctors here. So we welcome patients. If you see patients with this diagnosis, I'll hand over to Dr. Gao.
Okay, thank you so much, Dr. Morita. It's been a pleasure working with you, and seeing the results has been just amazing. We have so many more examples, but I think the ones that you cited really touched the core of, how essential tremor and Parkinson's disease really affect people, and how novel treatments like this are so important to help our community. So thank you. I'll stop sharing now.
Right. Thank you very much, Dr. Fay Gao and Dr. Michon Morita. That was amazing. I'm glad that we have this here at Queens to help those people that have those conditions. Wow. So right now it's time for Q&A. Let me look at the chat box. Anybody have any questions? So, and if you have any questions, feel free to type them in right now. I don't see anything there, but all right, I don't see any questions, but yeah, how did you get any feedback from their families in terms of for the patient, like especially the one in Kauai, in terms of their family? How are they? I mean, how is it like? From their standpoint, in terms of the day-to-day change because of the procedure.
Yeah, the patients that I've seen are just, they're in tears right after the procedure is done, because one of the patients, he's a very, very stoic, older Japanese man. I put that stereotactic frame on, and it's really painful. He didn't flinch at all. And when after we took the frame off, he literally had tears in his eyes, and he said, "It's been so long since I could just use my hand functionally." He was talking about how much he enjoyed fishing, but he couldn't tie the hooks and couldn't tie his lures, and he had to ask someone else to do it for him. And he said he's going to go fishing, and it really changes people's lives. Today, the procedure I did, the very first thing that the patient said afterwards was, "This is transformative. This has transformed my life." So it's in neurology and neurosurgery, we don't have that many totally happy cases, but it's like, for me, it's like delivering a baby or something. It's so nice to have somebody so happy.
Wow. Yeah, thank
I
you
think
for sharing.
to answer your question, Eric, the family members are equally, if not sometimes even more happy with the outcomes, because they are the ones who have taken over a lot of the the manual tasks and activities that the patients can't do, and they're the ones who get frustrated by the amount of social isolation and oftentimes depression that patients have from not being able to be independent. So I think our family members have given a lot of positive feedback as well.
Very good. All right, we do have a question on the chat box, and the question is, how long do you expect the benefit of the treatment to last?
Yeah, we expect that the benefit will be permanent. So if you compare it to like radiofrequency thalamotomy, those patients may have some progression of their tremor, but they're still dramatically better than the control side, the untreated side. And that improvement tends to be forever. We do a follow-up MRI scan. They have a therapeutic lesion, so that area of tissue is dead.
Also, when you were doing your presentation, you mentioned about the age, and the age was pretty young. I mean, are there a lot of patients that have these issues at that young age?
At the young age.
Yeah. So there are, and again, we think the basis of that could be genetic factors. There's actually what's called a bimodal distribution of age of onset, meaning there's sort of a peak of essential tremor starting kind of in the adolescent and young adult years, and then another probably bigger peak in older age. In general, it does progress over time, which is why, most patients who have more severe and disabling tremor are on the older side. But oftentimes what we hear is that they've had tremor for decades, ever since they were younger. But again, because of, a combination of misinformation and the sort of lack of good treatment options in the past, they're under the impression that there's nothing that they can do about it. So we're hoping to, educate the medical community as well as the general community that there are very good options now.
It's amazing. Let's see here. Just comment that was a great presentation. If no more question, then that concludes our Speaking of Health for April. Again, thank you so much for our speakers, Dr. Gao and Dr. Morita. Again, Queen's West Oahu Virtual Speaking of Health Lecture Series, the third Thursday of each month at 12 noon to 1 p.m. Please join us for the next lecture. We're scheduled for Thursday, May 16th, and our speakers will be Dr. Samuel Sapiti and Natalie Adolph. And the topic will be understanding acute stroke symptoms and the power of thrombectomy. So we look forward to you joining next month. And on behalf of our Vice President of Operations, Robin Kaholilani, our Chief Medical Officer, Dr. Ronald Kuroda, the entire Queens Medical Center West Oahu Ohana, Mahalo nui lua. Thank you very much for joining us today. Until next time, please take care and always be safe. Aloha.